Thank you all. It's just been super being here and getting in touch with all of my fellow classmates, seeing what they've been doing in the last 50 years. And I'm very honored to be able to tell you a little bit about what I've been working on too. I'm going to try to tell you a little bit about my career, but also throw in some things about how things have changed in the last 50 years. Very briefly, I entered MUD as a chem major, but graduated as a math major. Spent a couple years as a scientific programmer. Went to graduate school in math, but graduated in biostatistics. Spent my career as a professor of biostat and health services, and I retired in 2008. I changed from chemistry to math because I was so bad in lab. Also, it gave me a lot more time, but I did really fall in love with probability and statistics by senior year. When I left Harvey, I guess I was the least ambitious person in the class. They gave us a thing to fill out about where are you going next, and I guess I didn't fill it in. And so somebody filled it in for me as housewife. The truth was, my plan was just to, when I got out of college, I was going to go look for a job, which I did. At ITT Federal Labs, they asked me if I could teach myself to program. You may be surprised that at Harvey Mudd, I was a graduate, and I didn't know how to program a computer. I mean, Harvey Mudd actually had a computer. I had seen it, and I had seen it calculate square roots. I mean, this was really great, but I had never done anything with it. Things have changed a teeny bit. Huh? I was to program a Bendix G15 computer. Bendix, you probably have heard of because they make washing machines. This was a little challenging. It had to be done in assembly language. It had paper tape system, and it was so small that you couldn't have your program and your data in core at the same time. It was great fun. I moved up to a slightly bigger group, and one of our responsibilities was to help the engineers with doing their research. But the engineers were so cheap, they would not pay for the computer time to get this done. They thought they'd rather do it on their slide reels. I think this is fabulous. And probably some of you don't realize that computer time used to cost something. How about that? After a few years, I went to graduate school at UCLA, and I started out in math, but I found about this new program called Biostatistics. It's sort of what you would think. It's statistics, but applied in the biological areas. This was a brand new program, and somehow I managed to get through it without taking any bio classes at all. I was about to move to Seattle when somebody noticed that, and they said, you've got to take something. So they found me this class called Health Services Research. Weird class. It was the strangest thing I'd ever taken. And then I spent my career as a professor of biostatistics and health services. That was actually the job that was available when I started looking. Now, health services is usually defined in the negative. We're not the ones who try to find out what causes cancer or how to cure it. But we would be the ones to evaluate how that cure was dispersed, say, in the population, or in general, we'd be trying to find efficient and fair ways of improving the health of the public. So that's just about everything in heart. It couldn't be considered health services. The background required wasn't really bio, it was really more social sciences like economics and psychology and things. So it actually worked quite well with my background. I think you all know that faculty are expected to do teaching service research, and that research can be theoretical or applied. In my career, about 40 years, I did all of those things, but mostly I did applied research because that's where my money came from. Science, we all know the research, start out with an idea or a hypothesis. You need a study design to try to test that hypothesis. Then you have to apply for funding. In this case, usually to NIH or to maybe a foundation. Data need to be collected, managed, and analyzed, and finally there's a publication. Biostatisticians usually participate in the study design and in the data sections, but in my career I have done all of those things. And they're really all fun parts except for begging for money, never fun. I'd like to mention a couple of, well, 3 applied studies that I've worked on that I thought you might find a little bit interesting. But first I have to mention something not interesting at all, my dissertation. And I'm only mentioning that because I started it out with an anecdote from HMC Chem Lab. We used to have this thing called an analytical balance. And it was this thing you had to use to weigh things, and I was really bad at this. I could never get the same answer twice. So our protocol was to weigh everything 3 times and find the closest 2 and average those and use that. And one of the things I did in my thesis was show this is a really bad way. It really makes your estimates less reliable. I'd like to talk to you about small area variation analysis. You probably think you've never heard of it, but you have. It's in the newspaper all the time under different names. A rate of something or other is calculated in a bunch of small areas or units of some sort. In this case, it's the surgery rate in the 39 counties of the state of Washington. And you can see there's quite a bit of variability. County 39 has a rate of 8,000, where County 1 has a rate of only 1,000. Now, health policy researchers look at things like this and say, oh my goodness, the highest is 8 times as high as the lowest. Something must be done, right? This shows that there's waste in the healthcare system. Obviously, the high rate can't be right because the others are having low rates. So what should we do? Now, a statistician might say, well, of course the maximum is bigger than the minimum. That's kind of the definition. And the theory of order statistics tells you, very unintuitive, is that the maximum can be a lot greater than the minimum, but just by chance. Also, small counties have very variable rates, and so they could look really high one year and really bad the next year. And the analysis is implied by that picture is actually that you should compare every single county to every other county. And by the time you've accounted for all these things, you discover that differences that look really big in those rates are not what we call statistically significant. So I wrote a paper about this, and my greatest hit. I won a prize as the paper of the year for something that I thought was pretty obvious to any statistician anyway. Now, for something completely different, diagnosing pneumonia in patients with cough, which I worked on in the 1980s. I was working at the public health hospital, and the doctors there had a contract with the Army. The Army wanted to save money by not using doctors to diagnose people with simple problems like cough. And so they tried to find a way to do this safely using non-physicians or corpsmen. So the doctors I worked with developed a checklist, and so the corpsmen had to fill out every single item for every single patient, and this was done for quality control. Then these things were put into a computer, and the computer looked to see if they'd done the right thing. Now, in the 1980s, this was a huge, big deal. The Army had to go out and buy a computer. It had to go pay somebody to develop software to do this. It had to pay someone to train someone to enter the data. And it was really an amazing thing. I mean, today this would take 10 minutes, but then it was really a big deal. Now, to me, it was a big deal because I had data. This was terrific. And even better, for a while, they were taking chest x-rays of every single cough patient because they wanted to make sure that they weren't missing any pneumonia cases. So the doctors I worked with wanted to study whether physicians were ordering chest x-rays efficiently. And they wrote a nice paper about this showing that physicians ordered chest x-rays on all the wrong people. I looked at this, though, and said, well, why don't we just do a regular statistical analysis? We know who has pneumonia and who doesn't. Why don't we just see how to predict this? So I also wrote a paper on this. 20 years later, a colleague of mine used my paper as an example in one of her classes. And one of her students, who was an MD, told her that this paper was actually really very, very famous. And it was quoted in a lot of medical textbooks and things. I just had no idea. You know, you kind of write these things and they just disappear. So recently I took a look on the internet, and here's what I found. the Diehr rule for diagnosing pneumonia. So this is indeed our rule, but in fact, it's all programmed up now, so we could do this. The idea was you would ask the person these 7 questions. You get 2 points if you have a fever, 2 points if you have a high respiration rate, 2 points for lots of sputum, 1 point for lots of sputum, 1 point for night sweats, 1 point for myalgia. You lose a point for sore throat and lose 2 points for rhinorrhea, which is just runny nose. Then you add all those up, and down there we have estimates of the probability that you have pneumonia. I think it's pretty easy to see that you could come up with some kind of a rule in which you would treat the people with a low probability of pneumonia differently from the people with a high probability of pneumonia. I thought there were some very interesting features of this thing now that's called the Diehr rule. First of all, you might wonder about that point system. Where did that come from? Well, those were just simplified regression coefficients. But at that time, well, I got this idea from one of my students who was an MD, and you couldn't even expect a doctor to have a pocket calculator. So there's certainly no way that you could expect them to evaluate an important, complicated equation. So that's why we simplified everything to that point system. We thought it surprising that some of those variables had negative signs. We'd never really thought about that. You'd think that the more things that were wrong with you, the more likely you'd be to have pneumonia. But it turns out that runny nose suggests you just have a cold, and it makes you actually less likely to have pneumonia. So that was pretty interesting. Also, I think you'll see that there were no fancy variables. Any one of us could have answered those 7 questions. Now, our data set actually included a lot of stethoscope findings. You know, you have to breathe and all these things. But they didn't really improve the prediction very much. And so as a result, our rule was so simple that it could just be used over the phone. You have a cough, you call, talk to the nurse, she asks you 7 questions. If you have a high probability of pneumonia, she probably has you come in, otherwise she tells you to get some bed rest or something. So it ended up being kind of a nifty rule. But I think the real reason that the paper was popular was that every single person got X-rayed, and that's just incredibly unusual in data sets that you get an outcome on every single person. Well, one day the mainframe had to be abandoned, and I thought I had gotten the data off the mainframe onto a tape, and then from onto the tape onto a floppy disk, but something failed in there and the data's lost. It's really very sad because it would be just such a fun thing to reanalyze. Right now, I'm interested in aging. It started out as a professional interest, but now, of course, it's also a personal interest. I've been a member of the cardiovascular health study, where we're following about 6,000 people ever since 1990. They're a random sample from Medicare, so things we find out about these 6,000 people can sort of be generalized to all older people in the United States. Mostly, we followed everybody for 9 years, so we stopped following it in 1999. But for a few variables, we're still collecting them. And so I'm going to tell you now about 19 years of follow-up on 2 variables. One is just plain old years of life or survival. How many years out of the 19 did the average person live? And then years of healthy life, how many of those 19 years did they say they were healthy? Okay, so here's what the data look like. These bars that you're looking at are 19 years high, and the colors just show the distribution of how the average person, how they spent their time, being dead, being sick, or being healthy. You'll see that the black bars, number of years lost to death, are much bigger for men than women. No surprise there that men don't live as long. But the green bars are almost exactly the same size. So what is this telling us? It's telling us that women live longer, but they spend all their extra years being sick. Maybe not as good a deal as you would have thought. Okay, now let's add weight into this analysis. I've actually published 3 or 4 papers about weight, mortality, and health, but I've never published anything with the 19 years of data. So you are the first ones to get to see this, you lucky things. Okay, so probably everyone knows that we're in the midst of an obesity epidemic, that most Americans are overweight or obese, and something must be done. When we talk about weight, we don't really mean weight. We usually talk about body mass index, which is weight over height squared. Now, tragically, this is defined in kilograms and meters. So no Americans could calculate their BMI until just recently. Now I'm sure there's an app for that. So BMI is usually or often reported in 4 categories: underweight, normal, overweight, and obese. You might wonder, where did these categories come from? Well, the category that's called normal is the range in which mortality was the lowest over a large number of data sets. Why they called it normal, I have no idea, but that's why it was chosen. Now, these data sets mostly didn't have people over 65 in them. Why? They just never used to include people over 65 in studies because they were going to die any minute, because who knows? And so once Medicare came in, of course, we've got much better data now. So all right, so let's see what that looks like. And we discovered that in our data set, just as we feared, 60% of the seniors are overweight or obese. So this is really a terrible thing. Now, I kind of wonder, do those BMI categories even make sense for older adults? I mean, the data were all for younger people. Do they make sense in terms of health as well as for mortality? And finally, is overweight really worse than normal weight? Okay, so we're going to use our Years of Healthy Life bars to look at that. Those are the 4 weight categories. You'll see that in terms of the black bar, which is the years lost to death, the unfortunate group is the underweight group, whereas the other 3 are all pretty similar. The green bars, years of healthy life, normal and overweight look pretty good. Obese is a little worse, and the underweight is, again, the worst one. So you really don't want to be underweight. Now I'm going to talk I'm just going to restrict it to talk to normal weight and overweight, okay, to make these graphs a little bit simpler. And as we said, they're pretty similar. Now you might wonder if is that just because all the women are in one group or all the oldest people are in one group. So here it's broken down by age and sex. For instance, that upper left one is the oldest females, who were 75 to 84 when they started the study. And you'll see that the black bars are about the same, the green bars are about the same. And if you look at the other 3 panels, you'll see that that's the same almost everywhere, that the overweight look at least as good as the normal and maybe even a little better. Another thing you would worry about if you were a health person is smoking. Smoking is a thing called a confounder. And it's because smoking makes you weigh less, but also makes you sick and die. And so the thinnest people could look bad because they were smokers, not because they were thin. But I think if we divide them up into these 3 groups, so the never smoked, the former smokers, and the current smokers, then in each one of those, the overweight look at least as good as the normal weight, right? The overweight have the same size or smaller black bars and the same size or larger green bars in every case. So it's not a smoking issue. So in this rather tiny analysis, we found that for older adults, the overweight live as long as the normal weight, the overweight are as healthy as the normal weight, and that's true even after counting for age, sex, and smoking, and a bunch of other variables in a regression analysis that I won't show you. So I conclude that normal and overweight are both healthy weights. And if we look at the same graph, we can now change the label on it to say, wow, 81% of seniors are at a healthy weight. Isn't that great? And instead of something must be done, we can say, let's worry about something else. Okay, I feel it's my duty to give you some words of wisdom, even though I know most of you have got your careers all set already, but you probably have children or students or something this could be useful for. First of all, it breaks my heart that in all the time, 40 years that I've been in the #1 Department of Biostatistics in the world, we've had 1 person graduate who had been at Harvey Mudd as a math major. Now, tell your math majors, this is really a great career. You use your theory skills, you use your applied skills, you do something socially useful, and it's really easy to get a job. There's really huge demand for biostatisticians, so I recommend that. Second, that working in brand new areas is really a good thing. You can do some things that are just kind of obvious, and everybody thinks you're brilliant. I personally liked working collaboratively with doctors and economists, et cetera. But sometimes my own ideas helped too and came up with some new knowledge. So I'd recommend that you stick with your own ideas too. And even if you're not interested in research, I have advice for everyone. Keep CLAM. Scary graphs, maybe you're just scary graphs, but they really might not mean anything. So thank you very much.